Hello everyone. Today will be a little bit on the pharmacology of diuretics, right? Diuretics is actually part of a very big, popular family of drugs, which is used within different types of cardiovascular disease. It's mainly used for hypertension and also in heart failure, right? From the name diuretics, you know that the drugs which are considered in this group will actually increase the amount of water excretion, right, through the body, meaning just to get rid of the water out of the body, right? So we're going to go through all of it in this particular class. So if later in other sections, if you look at diuretics, when you want to check on their mechanism of action, please refer to this section, right? So to understand diuretics, first of all, you need to understand how it works for the normal kidney physiology, because obviously there's different sections in the nephron and the different drugs will actually target the different sections. The different sections that it targets actually again reflects into the ability or how much water that it can excrete out as well. So all this information are tied in very closely together. So if you're a bit blurred, so remember to go back and do some of the revision. But we'll go through some of it over here as well. Right, so it starts off with the glomerulus, right, and then you got your proximal convoluted tubule, goes all the way down to the loop of Henle, and then you've got the distal convoluted tubule, and also later on to the collecting duct as well. And another concept that you need to understand is that the water reabsorption is a passive process. The water flow is not something that you can control directly, so you can actually control indirectly by controlling the amount of sodium reabsorption. So basically, you just follow where the sodium goes because it's trying to dilute the whole thing so that it's not over thick or concentrated. So in all the diagrams, as you can see, it's actually at there's different sections. So this is the blood section, and this is the one touching the nephron fluid or whatever you call it, right? You can see here there's different pumps available. So there's specific locations for specific pumps. So you can see that if it antagonize one of it, right, then the sodium will be lesser, be reabsorbed, right? So again, the sodium will travel from one end into the other end eventually, and this is another section which is at the ascending limb, right? So you can see there's different types of pump again, so details we'll again look at it later on as well, right? Again, as to re-emphasize the point that water follows the sodium. Okay, so for this slide again, to re-emphasize the role of different sections of the kidney, right, of the nephron, sorry. So we've got the function, right, where the diuretics will affect, and also the secreted peptides and so on, like renin and so on, is again also part of the function of kidney, will actually be targeted and inhibited, like for ACE inhibitors and so on, which is already covered in the other class. Right, so and bear in mind, just a reminder, drugs that targets the kidney and all, they should not be used for gestational hypertension, or another name for it is the preeclampsia, because it's contraindicated because they are teratogenic, right? So we'll talk a bit about diuretics. The main thing that I need to know is where does it act for the drugs, where does it act, how does it act, right? Of course, like mechanism of action, and also the indication. Right, so there's different drugs, as you can see here, that target different parts. So we'll start off one by one from the proximal convoluted tubule, which is the first one after the glomerulus. Right, this is where the carbonic anhydrase ones. And the second part, which is the loop of Henle over here, which is the loop diuretics for loop of Henle. And you've got distal convoluted tubules for thiazide diuretics, hydrochloric thiazide, and so on. And you've got your potassium sparing ones over here as well. So we'll go through part by part, but before that, we'll go through a drug very briefly called Mannitol. So it's actually an osmotic diuresis, whereby it's a small molecule, so it doesn't absorb much, right? It's filtered, but not subsequently reabsorbed, so it causes an osmotic force, so it would then cause the water to get out of the body, right? So it's actually not really used for cardiovascular conditions, because it's something too strong in a way. You actually use it for cerebral edema, so you actually see it more to use in the neurological ward rather than the cardio ward, right? So this is for a lot of cerebral edema, which could happen commonly occur during after surgery or after certain accidents, right? So again, something you have to monitor very closely, because it causes a lot of electrolyte disturbance. Right, so for proximal convoluted tubule, it's actually, when you look at the percentage of sodium reabsorption, so you can see that it's somewhere that if you affect it, there's quite a lot of changes in the water reabsorption as well. So theoretically it's the strongest, but later on we'll look through the reason why it's not being used for cardiovascular conditions, because the effect doesn't last literally as short as that. As simple as that. So these are one of the conditions whereby pharmacologically it could work, but actual fact there's other compensation and so on that kicks in that renders it useless literally as a drug for cardiovascular, but can use it for other conditions. So we'll still go through very briefly. So what happens is that this acetazolamide is the name of the drug. It actually inhibits this particular enzyme actually called the CA1, CA2, so which is carbonic anhydrase enzyme type 4 and also type 2. Sorry, my mouse. Right, so you can see here for the ions, for H2CO3 to break down into CO2 and water, you require the action of this enzyme. CO2 and water can easily diffuse across the membrane, and then you need the enzyme again to reconvert it back to H2CO3, which then, as the ionic form, it can dissociate by itself into ionic forms and then get reabsorbed into the body, right? So therefore you can see here there's H plus involved, therefore bringing the sodium reabsorption in the body as well. So if you cut down this whole process, eventually it causes a reduction in the sodium reabsorption as well. So you can see it also affects the H plus ion, right? So there's more diuresis because of that. So acetazolamide, so you can see you need to know how it works. This is a non-competitive, it's a reversal inhibition, right? However, as mentioned before, the effect only lasts a few days, right? Because there's compensation. So it can actually cause mild acidosis, because if you use the drug, it actually inhibit the proton ion secretion, right? Because there's less that's going to be reabsorbed, right? So you can produce more alkaline urine. So actually this drug is used for glaucoma and for acute mountain sickness. So it's a bit rare to use actually. So glaucoma will be available in eye drop form, because the same carbonic anhydrase enzyme is also available in the eye. Right, so a second part, which is the thick loop of Henle. Sorry about the diagram. Okay, diagram should appear first. Okay, so what happened is that you can see there's this specific pump over here. So this is a co-transporter. There's this NKCC2, which is sodium, 2 chloride ion, and 1 potassium ion. So the drug, what happens is that it can actually inhibit this section. So when you inhibit this, so you can see that there's lesser sodium being reabsorbed into the nephron cells. There's lesser eventually that can be reabsorbed into the blood. Straightforward as that. So however, this section is also responsible for the reabsorption of divalent ions as well, which is the calcium and magnesium. So divalent because there's 2 plus charge. So because the whole reabsorption process over here actually causes imbalance of charges, therefore it can just flow through directly to balance out the charge. So you can see the drug, if it affects over here, it can also have an effect on the absorption of calcium and magnesium, right? And also a little bit on the potassium as well, because the potassium reabsorption is also reduced, right? So, and this one is a little bit stronger as well. So because it's in charge of this whole site here, is involved about 25 to 35% of sodium. So therefore, you can see there's more water that can be kicked out of the body if you play around with the system over here. So for the drug, it's the strongest diuretic that you can use, right? So as you can see here, so it can cause a lot of these ions being excreted. So therefore, you have to monitor. It could possibly cause hypokalemia, hypomagnesemia, hypocalcemia, and so on. So the most commonly used drug is furosemide. So furosemide is the oral one. So that's how the explanation that you need to know for exam purposes. So you need to know how What's the effect? It inhibits sodium reabsorption. How? Competitive and reversal inhibition of this NKCC2 co-transporter, right? At where? Right, so as mentioned just now, these are the tags, so you have to monitor all the other ions as well, right? And bear in mind, hypokalemia can also precipitate arrhythmia. So again, it's something you have to look very careful, because a lot of people with when you actually use loop diuretics, is actually for those with heart failure, so meaning their heart condition is not very good already. So again, you don't want the plasma potassium level to be off in a way to precipitate an arrhythmia episode. So there's other examples of drugs like bumetanide as well. So the main effect is ototoxicity. So again, because it affects the nephron, somehow it affects the ears as well. So try not to give it with another drug which can also cause ototoxicity, like aminoglycosides, which is an antibiotic. So again, because it's a strong diuretic, you want it to reserve it for conditions whereby the person is actually having an episode of edema. So it can be edema due to heart failure, but again, bear in mind, you don't overuse it, because resistance towards diuretics can occur as well, right? So the effect is actually kicking quite quickly, so we normally try to advise the patient to take it in the morning, right? So i.e. do not take it before the person has to go for a long road trip, for example, because again, it might be tricky. The person have to keep looking for the toilet, or don't take it before night time. If not, the person have to keep waking up at night. Again, all this will reduce the compliance of the person towards the drug, right? So try not to interfere with the sleep too much. The BD, the second dose, try to take it earlier. Right, so another part, which is the thiazide diuretic. So you can see there's different types of pumps again occurring here. This is the NCC pump. So you can see if you actually inhibit this pump, you reduce the sodium reabsorption here. It reduces the sodium reabsorption into the blood. So for this one, it only affects about 10% of the sodium. So you might say, is 10% enough? Yes, it is enough for control of hypertension condition. So the main drug that we're looking at is called hydrochlorothiazide, whereby it actually inhibits competitive and reversibly at the co-transporter. So it has modest diuretic effect. It's mainly used for first line for hypertension for older people, because there's not much evidence on improving the long-term mortality and morbidity. Right, so it's safe, minimal disturbance to all the other ions, because it's not the strongest as well. Right, however, some of it you can use in combination if required for those resistant cases with diuretics, and it can also causes a little bit changes, but not so much. But bear in mind, it can also affect the glucose and lipid profile of the person as well. Hydrochlorothiazide is the most commonly used one, right? So a little bit of diuresis effect, but not as strong. Right, so for here, we're actually going to touch through two classes of drugs, the last two ones, which act mainly on the collecting duct. So the first one is the potassium-sparing diuretics, and the second one is on the aldosterone antagonist. So we'll go through one by one. So the first one about the potassium-sparing diuretics. So it's actually acting on this specific sodium pump. So we've got examples like amiloride and triamterene. So you can see over here, when you have less sodium reabsorption through this specific pump, this ENAC pump, right? So which then causes lesser sodium reabsorption eventually into the blood. So you can compare to the other diuretics just now. It's always a sodium plus potassium pump somehow, with different combinations, of course. So, but for this one, it's actually omitting the effects of potassium altogether. So therefore, it's also called potassium sparing diuretics because of that, because it doesn't really affect the potassium level that much compared to normal. Right, it's just very minimal changes. So it could be some increase in potassium because of the after effect of this particular pump, but then it's not that strong unless you use it at a very high dose. So the second part is the aldosterone antagonist. So you've got spironolactone or eplerenone, which actually antagonize the enzyme over here, for the mineralocorticoid receptors. So it actually causes a very indirect effect whereby if this inhibition occurs, it actually prevents reduces the new sodium potassium ATP pump being produced, because obviously the more of this pump and also this particular pump would then sodium pump would then causes overall lesser sodium reabsorption in the long run. Right, so the side effects that I need to monitor over this for these two sections is actually more on hyperkalemia. Right, so a little bit detailed. So it's a competitive inhibitor. So it's a weak diuretic. So it can be used in combination, but it's not that popular. It's not that popular option, right? But you can use it if you really need to. So it's not to be given with potassium supplements, because for like furosemide, if they are on a very high dose, they could be given potassium supplements to prevent or reduce the hypokalemia condition. So, but then this is just to let you know some drugs. In this case, triamterene is pretty interesting because it can actually make the urine look blue. So these are the small points, harmless points that probably you should tell the patient during counseling in case the person get a big shock. Right, so because obviously it's abnormal. So we've got spironolactone eplerenone, so you can see the details over here. So indication, you can use it for hypertensive, especially for obese patients somehow, because the more the adipocyte actually increases the aldosterone synthesis that they found, so it's more useful for this subgroup of patients. And it's also the main usage is on heart failure as well, because it's found to reduce the remodeling of the heart in heart failure, right, for eplerenone. Spironolactone has a wider use as also on the hyperaldosteronium situation, because spironolactone is the more non-specific antagonist. Right, so again, do not give with potassium supplements. So you can see here, this is a summary of how the different drugs on different sections can actually influence on the urine electrolytes. And hopefully by the whole thing, you can actually understand this particular chart. If you're done, if you understand this well, then congratulations, you understand diuretics. See you next time.